Well, welcome back everyone to our Critical Care Symposium. I am so looking forward to hearing this next talk. Dr. Mark Sutherland, very similar to Dr. Cami Hu, is a graduate of our EM/IM Critical Care Residency Program here at Maryland. We were fortunate enough, just like Cami, to keep Mark on faculty here at Maryland, where he does, in fact, split his time between the medical ICU, the ED, and, well, and a sundry of other things that Mark does. But with respect to shock and critical illness, he is going to talk to us about uncommon causes of shock. As I mentioned, heading into the break, what happens when it's not sepsis? It's not heart failure or cardiogenic shock. It's not hemorrhagic shock or an obstructive cause. What are some things we need to think about? So, Mark, take it away and give us some pearls.
Well, thank you very much, Dr. Winters. Thank you to UMEM for the opportunity to speak today. It's an absolute pleasure. As Dr. Winters alluded to, I have the privilege of working both down in the emergency department and up in the medical ICU. So try to merge some of those perspectives and think a little bit about what to do when you're a bit off the beaten path and some of the more common causes that we normally are chasing after when we talk about shock don't seem to be turning up as the potential issue. So the first thing, before we get into specific diagnoses, I want you to do 4 things for me. And the first thing is think about whether you're treating shock or you're treating hypotension. And Dr. Winters expertly went through this, as always, of course, before, and talked a little bit about the definition of shock. But just a reminder that hypotension is about a number, whereas shock is about end organ dysfunction and failure to meet the metabolic needs. On a minute-to-minute basis, the thing that the tissues in your body need the most is, of course, oxygen. So typically when we talk about shock, we're talking specifically about inadequate oxygen delivery to support sustained life in all of those cells. Usually when we talk about shock, we're also describing kind of a global dysfunction throughout the body. If you have a LAD lesion and you've got infarction and ischemia downstream from there, we normally wouldn't call that shock. We're talking about a failure of the body as a whole to deliver oxygen and other metabolic substrates to the organs to keep them alive. When we talk about hypotension, on the other hand, you see I've got 65 on the screen there. That's because, of course, as many of you know, we often will target a MAP, mean arterial pressure of 65 or greater, and pay very close attention when it dips below 65. That should always be in the context of your patient. So if you have someone who's baseline hypertensive maybe, and they're there with a spinal cord injury, for example, that might be a very different number that you're targeting, but 65 would probably be the single most commonly used number. So think to yourself a little bit as you assess the patient. Am I dealing with hypotension? Am I dealing with shock? Or am I dealing with both? And as Mike alluded to, you can have shock without hypotension. You can also have hypotension without shock. They're kind of a Venn diagram and they often go together, but you don't necessarily have to have both. The next thing I want you to do before we get into uncommon causes is think of common things. So again, Mike went through this quite well before, so I won't belabor the point. Dr. Matu has taught many of us the acronym SHOCK, so let's expand it to SHOCKed. And there are slightly different variants depending a little bit on who you ask, but one of the things I really like about this mnemonic is it's roughly ordered, just I think by coincidence, quite frankly, kind of from the more common to the less common things. So as Dr. Winters alluded to and Dr. Hu talked about, sepsis is overwhelmingly common in our emergency department. So if you walk through the acronym SHOCKed, it will often walk you kind of starting with the more common things, slowly getting into more uncommon areas. And I'm going to talk about a few things that are at the end of that acronym and then some things that don't quite make the acronym because they're even too rare to be in our mnemonic here. But thinking through septic, hypovolemic, obstructive, cardiogenic, yes, the K, it's kind of unfair, anaphylactic, but, and then I usually use E for endocrine or endocrinopathies as the cause of shock. And then for me, I typically do D as disability, thinking of your ABCD, right, your primary survey for trauma. So that's your neurogenic or dyshemoglobinemias. And again, we're going to get into some of those as we go. So the first thing is, are you talking about hypotension, talking about shock? The second thing is think of common things first. Don't go chasing zebras when you don't have to. The third thing I want you to do is think through the physiology. Even if you can't come to a specific diagnosis, often that's okay. As long as you can understand the physiology of what's going on with your patient, that will tell you what the appropriate management should be. So again, Dr. Winters covered this, but thinking about those categories of shock we all learn about in med school, cardiogenic, distributive, hypovolemic, obstructive. Dissociative is when your hemoglobin doesn't work. Again, we're going to talk about that a little bit more. So those are your dyshemoglobinemias. But thinking about what do I know about the patient's physiology and what can it tell me about what I need to do next, even if I don't have a specific, ICD-10 code that I can put on the chart, what's kind of going on with the patient's body. And that's where I think pulse pressure actually can be a really useful thing to look at. I promised it wasn't a plant. I saw someone asked in the Vimeo chat earlier about pulse pressure. So again, a reminder, of course, most of you know this, your pulse pressure is your systolic blood pressure minus your diastolic blood pressure. So I've got two patients on the screen here. The top patient is a patient I took care of in the medical ICU last week. He had been transferred over to us with nivolumab-induced myasthenia gravis. Special shout out to Dr. Michael Scott, if he's listening. He had taken care of this patient over at St. Joe's and transferred him to us for plasma exchange. And this gentleman did very well. He was getting stronger with Plex, so we actually extubated him. And the next day, he had kind of gotten worse, was having more trouble breathing, got suddenly reintubated, and all of a sudden was hypotensive and in profound shock. In addition, he had a history of complete heart block. He'd had an NSTEMI in the past, had CHF, he had some heart problems. We weren't sure if his pacemaker was working. He was leaking some troponins. So my fellow and I were standing at the bedside for a couple hours trying to resuscitate this gentleman and figure out what was going on with him. And he was one of the most challenging echoes I've seen in a long time. So I'm a big proponent of ultrasound. It's great, but like anything, it can fail sometimes. My fellow and myself and actually the echo tech couldn't get good views. So we're standing at the bedside trying to figure out, well, is he getting septic? Is this related to his myasthenia gravis? Is this his heart problem? And one of the things that can sometimes clue you in the right direction when you're kind of differentiating shock is the pulse pressure. So remembering that, of course, your diastolic pressure is generated primarily by that systemic vascular resistance. And then the elevation from your diastolic up to your systolic pressure is really about the heart squeezing blood out with force and creating a higher pressure. And so that obviously relies on the strength and the ability of the heart to do that. So you can see by his, and of course, I took this screenshot a little later when he was no longer septic. He was actually off pressors, but you can see his pulse pressure is actually quite wide on that top graph. So that tells us, at least gives us a clue that there's something working with his heart. His heart may not be the primary driver of this. It's not a hard and fast rule, but it's something you can think about. The bottom graph, on the other hand, I took from a patient in the CSICU. You can see that very narrow pulse pressure. Dr. Greenwood, who's going to be speaking next, probably sees this a lot more than I do with the cardiac work that he does. But I remember as a fellow, for example, working in the CSICU and taking care of patients on VA ECMO, and you might walk in the room and they have an A-line that's reading 65/65. They have no pulse pressure. And then the next day you come back and their heart's a little stronger and their A-line's reading 70/65. And the next day it's 75/65. And that's a sign that their heart is getting stronger and they're generating some cardiac output. So this is a key clue that you have at the bedside. All you need is a blood pressure cuff to get this. And if I'm all for ultrasound and all of that, but if you can't get your views and things like that, this is a useful tool you can look at. The fourth thing I want you to do is brought to you by the letter H. So two kind of sub pieces to this part. And the first is history. So I want you to think carefully about as I go through some of these diagnoses, the historical elements that will point you towards these diagnoses or make them less likely. The key really here is in the history when we talk about more rare causes of shock. And in particular, a lot of these are questions that you wouldn't necessarily ask on a standard patient, especially if they're unstable and you're trying to stabilize them. So the key is really patient comes in, they're hypotensive, they're crashing. Take your basic history, just the things you absolutely need at ABEM General or wherever you're working, and make sure you stabilize the patient, focusing on common causes of shock. But if you're striking out, if the patient's not getting better, if it's seeming like maybe this isn't sepsis, maybe they're not hypovolemic, go back to the patient if they're talking, go back to the family if the patient's not talking, and ask some of these additional questions from a history perspective to try and help suss out whether it's one of these less common causes of shock. I think you'll all know those history questions as I go through these diagnoses, but just make sure that history is really important. The other H is heart rate. So heart rate is king when we talk about shock, and particularly when we start to talk about uncommon causes. Remember that heart rate is finely tuned by the body. It's one of the most closely controlled physiologic parameters, and the body will naturally respond, of course, to hypotension with tachycardia to try and drive that mean arterial pressure up. So bradycardia plus hypotension should always be weird. That's a huge red flag in your mind. If you're seeing a patient who's hypotensive and their heart rate, even if they're not technically bradycardic, if their heart rate's like 62, 64. That should make alarm bells go off in your mind. When we talk about common causes, right, going back to that shock or shocked algorithm or mnemonic, the first four things on there are very common, right? Sepsis, hypovolemia, obstruction, cardiogenic. Those are things we'll see in a typical month many times in the ED. Remember that all of those typically will present with tachycardia. So most of your super common causes of shock are pretty uniformly going to present with tachycardia. So it'd be rare, when you start seeing bradycardia, you want to start thinking about the rarer causes. Two quick caveats to keep in mind with that, of course. Older patients, as many of us know, are not typically able to mount the same degree of tachycardia. So if you're 95 years old, a heart rate of 90 might be tachycardia for you. The other thing is, of course, patients on beta blockers will often be unable to mount that tachycardia. So you do have to keep that in mind as you're assessing the heart rate. But again, bradycardia and hypotension, big red flag in your mind. So with that, I know it's not quite as much fun to do all this virtually. And so we're going to play a little game as we go through these diagnoses. For those of you who have the Vimeo chat open, feel free to throw things into the chat as we go. What we're going to do is I've got 11 causes of shock that are uncommon that I'm going to walk through. I'm going to start with the bradycardic ones and then do the tachycardic ones. But what I did was I threw the name of the diagnosis onto a PowerPoint slide. And for any of you who, like me, are PowerPoint nerds, and yes, I guess I just admitted on a recorded lecture I'm a PowerPoint nerd, but for any of you, you know that it does the design ideas thing and it will suggest an image for you or a video or something like that as your background. So we'll kind of play a little guessing game and see what PowerPoint did, just to make this a little more fun and kind of as the mental break as we go through some of this stuff. And again, I have 11 causes of shock, so this is gonna be super rapid fire style. Each of these could be a full presentation itself, especially by people who are more expert in some of these conditions than I am. But it's going to be a rapid fire look and kind of running through so that these are triggering in your mind when you're searching for causes of shock and the common things haven't really led you to a diagnosis. So a few bradycardic things. So this is the first one. This is what PowerPoint gave me as a slide when I typed in this diagnosis. I will say PowerPoint nailed some of these. It kind of missed the mark on a few of them. The area of interest is in this picture, but it is not in the center of the picture. The Vimeo is a little behind, so I won't see you live real time as you're throwing things in the chat. But if you want to throw anything in the chat, you think this could be a bradycardic cause of shock. This is spinal cord injury, right? So remember that spinal cord injuries cause neurogenic shock, right? You get, especially in blunt cervical injury, disruption of that sympathetic chain coming out from the brain. That's necessary to tell the body to squeeze all those blood vessels to generate some systemic vascular resistance. It's also necessary, of course, to tell the heart to beat faster. So this is one of those weird things that will present typically with bradycardia and hypotension. You will also see flush warm skin from that vasodilation. In addition to consulting your trauma surgeon, probably a neurosurgeon or orthospine, depending a little on your institution, you're going to essentially do standard hypotension type management, pressors, supportive care, et cetera. All right, how about this one? What did PowerPoint tell me this was a good slide for? So this one, I don't know. I see it, I guess, after the fact, but this was multisystem atrophy. So I guess it was thinking network computer system of some kind. So multisystem atrophy is a unification of a few diagnoses in the past that were separate. It's kind of a bit of a waste bucket diagnosis, a broad heading, if you will. You may recall vaguely the term Shy-Drager may ring a bell for some of you. I have never heard the term olivopontocerebellar atrophy, OPCA, or striatonegral degeneration, I don't think. But these diagnoses were kind of unified into the concept of multisystem atrophy. What these are is they're neurodegenerative disorders that thankfully are rare, unfortunately are fatal. And they cause disruption, just like your spinal injury, the last one we did. They cause disruption of the sympathetic outflow from the central nervous system. So these patients can present with orthostatic hypotension and the symptoms that go along with that. They can have postprandial hypotension, supine hypertension as a compensatory mechanism. And many of these underlying neurologic conditions have Parkinsonian features associated with them. So typically, this is an indolent process that will present over months to more often years. And obviously not a hard and fast rule, but most of the time patients will have come to the attention of a neurologist in the outpatient setting before they are crashing, dying in front of you in your emergency department. So a good review of the electronic medical record if the patient can't talk, or the patient, interviewing the patient and family, looking for this in their documented history can clue you in that they carry this diagnosis and it may be part of what's driving their shock. Obviously not a hard and fast rule, but often they will carry this or a similar diagnosis on their chart by the time they get to you. All right, this one I thought PowerPoint kind of nailed. This one's pretty good. It's one of the better ones. So this is calcium channel blocker and beta blocker toxicity. So a reminder, of course, toxicologic causes. There are a variety of toxicologic issues that can give you hypotension, but remember, calcium channel blockers and beta blockers are, of course, the classic. You will see this on boards, if not in real life. And these are vasodilatory medications, but they're also negative inotropes and chronotropes. So you can't get the compensatory tachycardia you would normally get with vasodilation. They may be refractory depressors. So you may need very high doses of your typical vasopressors to treat this. The first line therapy that's recommended is GI decontamination. I know that's a very controversial topic in toxicology, but that's what's recommended. And then, of course, your antidotes. So consider your high dose insulin, glucagon, calcium, et cetera. There is some emerging literature for methylene blue in calcium channel blocker overdose. And of course, salvage therapy tends to be ECMO for these. These patients typically are fairly good ECMO candidates because they have a clear reversible etiology, which you expect to get better with time. And it can be very challenging to manage them just with medical therapy if they're refractory to your pressors. So definitely think about ECMO. If you're at a facility that doesn't have ECMO, these may be patients you want to transfer out to an ECMO center depending on the clinical context. All right, how about this one? What did PowerPoint think this was a good slide? This one's a little harder. I'm not sure I get this one until after the fact. This was myxedema coma. Feels like it's going to put me into a coma more than represent one, but myxedema coma, remember, is your extreme presentation of hypothyroidism. So it's the end of the thyroid spectrum on the hypo side. It is a little bit of a misnomer. You do not have to have coma. You do not have to have non-pitting edema to be present. So lung pathology, I like that. That's a good guess. So typically myxedema coma will present with your standard hypothyroid type symptoms: fatigue, weight gain, constipation, cold intolerance. That'll be present usually over the preceding kind of weeks to months, and progressing to full-blown altered mental status, hypotension, bradycardia. Classically on labs, you'll see hyponatremia. If you recall your kind of up-to-date or whatever algorithm you use for hyponatremia, hypothyroid is on there. So if you see a low sodium plus bradycardia plus hypotension, you should definitely be thinking about the thyroid. Your standard therapy is going to be IV levothyroxine. Typical dose would be about 200 milligrams IV. And then you don't know if there's concomitant adrenal insufficiency. So typically we throw hydrocortisone at them as well, kind of empirically, until that is further sussed out. All right, how about this one? I love this one, by the way, the little like bouncing heart. It's kind of a cool. I admittedly cheated and threw a few different things together here on this one. So this would be sick sinus syndrome, heart block, heart transplant, a bit of a waste bucket diagnosis for you, but essentially any time that you are having shock and hypotension as a result of inappropriately low heart rates. So important reminder that your mean arterial pressure is your systemic vascular, or excuse me, your stroke volume times your heart rate, which is your cardiac output, times your systemic vascular resistance. So of course, if you have an inappropriately low heart rate and your body is not able to compensate with a higher stroke volume and a higher systemic vascular resistance, you're going to get hypotension. Interestingly, sick sinus syndrome is associated with hypophosphatemia and particularly refeeding syndrome. Not necessarily a diagnosis you would see a lot in the emergency department, but the title of this talk is Uncommon Causes of Shock. So the sinus node is particularly sensitive and needs ATP in a large way. So you can get bradyarrhythmias and other sinus problems when you don't have enough phosphate in your body. Of course, after heart transplant, we know that the classic teaching is that patients have lost their vagal tone, so they can't get bradycardic. In fact, there's a debate in the literature about whether you can have vasovagal syncope after a heart transplant. But after heart transplant, all kinds of weird things can happen. You can get bradycardias, you can get tachybrady syndromes, things like that. So something to think about if there's something in the physiology that's messing up the innervation of the heart. And then really depending on what the physiology and the underlying driver is, you're going to consider pacing, whether it be external pacing or TVP, isoproterenol, theophylline, terbutaline would be options as well. The other thing, I don't have it on the slide, but I'll mention here is you may, for the more nuanced folks, you may want to think a little bit about what pressor you're choosing in these cases. If the patient's hypotensive and you're going to start a vasopressor, this is one of the few times I would at least consider. I'm not saying it's right. I don't have good literature to support it, but maybe reaching for dopamine instead of norepinephrine. We, of course, don't tend to use dopamine very much because you get malignant tachydysrhythmias with it. So if you're trying to drive the heart rate up, that may be an option, or potentially leaning on epinephrine instead of norepinephrine. Just a thought. You're certainly not wrong with starting norepinephrine in these cases, but if you want to get a little more nuanced, you might choose a different pressor in some of these situations. All right, so a few tachycardic causes of shock. We've gone through the ones that typically would present with bradycardia. How about some things that are still rare, but would typically present with tachycardia? So this one, I gotta say, I don't know if anyone's gonna get this one. The PowerPoint really missed the mark. I can see in retrospect, I guess, why I guessed this, but this one's a little tougher, I will say. So this was an adrenal crisis. I'm guessing that PowerPoint latched onto the word crisis, not energy crisis or nuclear crisis or something, but adrenal crisis. So remember, just like myxedema coma is the severe end of the thyroid scale, adrenal crisis is the severe end of the adrenal insufficiency scale. So this is a patient presenting profoundly in shock and hypotensive, typically from adrenal insufficiency at the severe end of that spectrum. They'll typically have, again, some kind of systemic vague symptoms for the few days to weeks to months leading up to it. Weakness, fever, anorexia, nausea, vomiting, belly pain. Some of your cardinal findings will be often they'll have hypoglycemia and then electrolyte derangements, in particular your hyponatremia, hyperkalemia, and that will progress to confusion and coma. The dominant physiology here is distributive. So typically the heart is still working fine and they can mount the tachycardia. I will say for anyone else who's thinking here, doesn't adrenal crisis cause bradycardia? I kind of had that in my head as well. And as I kind of prepared for this talk, I tried to find some good literature, documenting typical heart rates in adrenal crisis. Couldn't find a lot of good documentation about it. But most of the time, these patients will present tachycardia because the principal issue is really about vasodilation and distributive physiology. Adrenal insufficiency itself is very frequently misdiagnosed. You can kind of understand why if you're a PCP, right? Very vague symptoms. This is uncommon. So do not be surprised if you have a patient in adrenal crisis, maybe you're considering this diagnosis, and you see they've seen their PCP maybe a few times in the last 6, 12, 18 months, and they have a diagnosis of fibromyalgia or chronic fatigue syndrome or irritable bowel, something like that on the chart. Don't rely on that diagnosis. Understand that that could be a misdiagnosis, and this could be adrenal crisis, which has really been adrenal insufficiency all along. Crises are fairly rare. Of course, we're talking about uncommon causes of shock. In patients with, it's not really known how frequently Addisonian or adrenal crisis presents as a new diagnosis in ED, but for patients with known adrenal insufficiency, they average about 6.3 crises per 100 patient years, so relatively rare. One thing when you're considering your management, you do want to keep in mind is in chronic cortisol deficient states, alpha-1 receptor expression gets downregulated, and so you may need higher doses of pressors than you're used to, kind of like your calcium channel and your beta blocker overdose patients. So don't be afraid to go up on those pressors if you need to. You're going to send a whole bunch of labs. I've listed a few for you here. And then if you're concerned for this diagnosis, you're going to start hydrocortisone empirically. Do not wait for your labs to come back. They may take days. So hydrocortisone, of course, is a medication we give patients in septic shock. We give patients sometimes in undifferentiated shock. There's relatively short list of contraindications to steroids. Some things you might want to think about if they have certain infections, but generally pretty safe med. So if you're concerned about adrenal crisis, go ahead and start the hydrocortisone. All right, how about this one? This one, I gotta say, PowerPoint nailed, but it's a rare diagnosis, so I don't know if anyone's gonna get this one. So this is systemic capillary leak syndrome. So SCLS, systemic capillary leak syndrome, also, again, the theme here is uncommon causes of shock, also a rare diagnosis. What happens is you can get this dysfunctional inflammatory response that leads to disruption of the endothelium, and then you get this massive third spacing of fluid. The patient will be vasodilated, and so they will tend to have a distributive physiology, but also a hypovolemic etiology because they're leaking fluid into the third space and it's not in the intravascular space. Typically on labs, you'll see hemoconcentration hypoalbuminemia. There is a form that's idiopathic. It's thought to be extraordinarily rare. As you can see in the next bullet point, it looks a lot like sepsis and very common things. So it's probably underdiagnosed. If it was common, we may not even know it. But true diagnoses of idiopathic SCLS are extremely rare. There have been less than 500 reported cases in the literature since this was first described in 1960. And again, you can see how this diagnosis is really hard to make. It'll be flu-like symptoms followed by an acute phase where they leak fluid into the third space, and then you have a recovery phase. It is known to be associated with viral infections. COVID and influenza are particularly notable. Hematologic malignancies, chemotherapy administration, growth factor administrations, and things like that. So systemic capillary leak syndrome. And that's fairly related to the next one. So this is what PowerPoint suggested for the next one. I like it. This one's pretty good. It did a good job on this one. So this was cytokine storm. So cytokine storm is admittedly a bit of a wastebasket diagnosis. You'll often hear us rounding in the MICU if you follow us around, just saying something like the patient's being SIRSy, right? If you remember your SIRS criteria. And all that means is there's some diffuse inflammatory state that is causing profound vasodilation and hypotension. And so sepsis itself can cause this type of physiology. It obviously overlaps with sepsis when it's infectious in nature, but also HLH, ARDS. Tumor lysis is a classic example of this. I've seen several cases in the MICU over the years where patients are in the cancer center, bad uncontrolled malignancy, they go into florid tumor lysis syndrome, and they just present to the MICU hypotensive, they've been started on pressors, they'll often have kind of a borderline fever, tachycardia, and they look exactly like sepsis. You really can't tell it apart. Aspiration pneumonitis is another great example. The story I told before about the gentleman with nivolumab-induced myasthenia gravis, his respiratory muscles were strong, but I had extubated him, and he probably was having some difficulty protecting his airway. The myasthenia was still affecting his head and neck pretty badly, probably aspirated somewhere along the way. The main differentiator there is aspiration pneumonitis will often get better in about 24-ish hours. True aspiration pneumonia, typically they'll be sick for days to weeks. This gentleman by the next day was back off pressors. He probably had a pretty significant aspiration pneumonitis. But really anything that causes severe inflammation can do this. So it looks just like sepsis. We treat it just like sepsis. Obviously, if you know this is not infectious, you don't really need the antibiotics. But the truth of the matter is, in the moment, there's almost never a reliable way to prove this isn't infectious. So typically, you are going to empirically antibiotic them. And then beyond that, it's really supportive care, trying to identify the underlying cause and then treat the underlying cause. All right, this one, I think this one was a little off the mark. This one's a little harder. I don't know if anyone's going to get this. This was cirrhosis. So just a reminder that cirrhosis by itself can cause baseline hypotension. We see this in our medical ICU all the time. We have a very active liver transplant program, so we get a lot of transfers in with fulminant hepatic failure. I sometimes jokingly refer to our MICU as the liver ICU or LICU. That's not a very popular name, but a reminder that cirrhosis by itself can cause both baseline hypotension and also if you have decompensated fulminant hepatitis cirrhosis, you can get hypotension that's added on top of that and shock. So I was always taught the physiology of that was dysregulated nitric oxide metabolism. And there is some truth to that. That's still felt to be the primary driver of hepatopulmonary syndrome. You're not clearing your nitric oxide because the liver participates in that. And of course, nitric oxide is a potent vasodilator. But really the primary pathophysiology drives through your portal hypertension. So of course, as most things do with cirrhosis, portal hypertension causes all kinds of dysregulation in the body. And you end up with this increased cardiac output, high output heart failure state. So classically, it's not uncommon. If you walked up into the MICU right now, you'd probably be able to find a patient who's there with cirrhosis and liver failure, and they might have a blood pressure like 130/25, 120/20, this crazy wide pulse pressure, and really just this vasoplegic pattern with the very low diastolic. But often these will be younger, otherwise healthier, alcoholics or things like that. So they have intact heart function and their hearts work quite well. They can generate that high pulse pressure, but they're very vasoplegic at baseline. So that would be a common cause of hypotension and one you'll see in the emergency department as well. Just in the interest of time, I won't go through it right now, but these recordings will be posted. The slides will be made available. This was an excellent review on the pathophysiology of cardiovascular dysfunction in folks who have cirrhosis. and they kind of walk you through, I highlighted a section there, how this unfolds. All right, two more. So this one I think is probably fairly straightforward. I mentioned it in the SHOCKed acronym before. This is the D, one of the Ds. These are your dyshemoglobinemias. So this is the weird one. Remember that as Dr. Winters defined before for us earlier, and as I mentioned as well, shock is about failure to give the cells the things they need to survive, typically oxygen. So you can perfuse the tissues with enough blood and enough pressure. If the hemoglobin's not working, you're still going to potentially have shock. There's a little bit of debate. Some people don't consider these to be shock states. I think it certainly fits the definition. So these are forms of what we call dissociative shock, meaning you're still perfusing the body, all of the tissues. In fact, your blood pressure may be high. The body is going to try and elevate the cardiac output, elevate the systemic vascular resistance, because it's getting this message from all the tissues, hey, help me, I don't have enough oxygen. So it's going to try harder to perfuse the body. But because something is wrong with the hemoglobin, they're not getting the oxygen they need to survive, and they can still get ischemic and still end up in a shock state. So this is your carbon monoxide poisoning, your methemoglobinemia, sulfhemoglobinemias, so your nitrates and nitroglycerin. Reglan, I had forgotten that metoclopramide can cause sulfhemoglobinemia, so something to keep in your back pocket. And then your cyanide toxicities as well. So a patient comes in from house fire, they've been on a nitroprusside drip for 7 straight days, bioterrorist attacks, sometimes we think about cyanide. So something to think about, is there enough blood getting to the patient, but some weird reason why the hemoglobin's not working, or something else that's going wrong with delivery of the actual oxygen. And then this is my last one. So I thought PowerPoint did a pretty good job with this one. This would be very rare in the emergency department, I will say, but again, I was tasked with uncommon causes of shock. So this is propofol-related infusion syndrome. So propofol-related infusion syndrome, and thank you to whoever created the acronym and included the R, so it's not PIS, this is PRIS. The mechanism is not completely clear. You'll see some hand waving on this slide, and the literature, there's debate about how exactly propofol-related infusion syndrome works, but it's felt to relate to maybe impairment of fatty acid metabolism. There's theories about disruption of the electron transport chain, blockage of beta or calcium channel receptors, and it'll present essentially with very wonky labs. This is the short version, right? You'll get high triglycerides, you get this raging anion-gap metabolic acidosis, rhabdomyolysis, hyperkalemia, acute kidney injury, transaminitis, and you can get cardiac dysfunction as well. The management is pretty straightforward. You're going to stop your propofol. You can think about hemodialysis if it's indicated, pressors if you need them, and then eventually ECMO. So the lesson here really is you want to consider maybe sending triglycerides periodically if you have patients who are on high doses of propofol for long periods of time. I know ICU boarding in REDs is bad. Hopefully it's not bad enough that you have patients on propofol drips at 70 for 4 days boarding in your ED. That would be really bad. But if you're in a rare situation where you've got high dose propofol running for a long period of time, it's something you may want to think about. So rounding it out, a few things I want you to walk away from besides this kind of random laundry list of things to pull out of your brain when you have a patient who's shocked you can't figure out, general approaches that are useful. The first is, again, circling back, differentiate between hypotension and shock. Not to say we don't care about hypotension without shock. We should still pay attention to it, but it's a bit of a different situation than shock. So think a little bit about, am I dealing with hypotension? Do I have end organ dysfunction? Am I dealing with shock? Think of common things before you start chasing zebras. That should be obvious, but as Dr. Winters alluded to, as Dr. Hu talked about, usually it's sepsis. I'm known in the MICU to say it's always sepsis. It just feels like it is. So common things are common. Don't start chasing after these until you've ruled out some of the common things. Work through the physiology. So both in the emergency department and in the ICU, it's very common that we will not be able to come up with a specific diagnosis. I don't have an ICD code I can put on the chart. But if I can understand the physiology, if I can use the data I'm getting from the exam, from the vital signs, from the labs, from everything I'm observing about the patient, to understand what's going on with their physiology, the management will be apparent and can flow from that. And so it's okay if you can't make a diagnosis, so long as you can understand the physiology and the pathophysiology. And then last but not least, brought to you by the letter H, remember to use your heart rate and your history to eliminate possible causes. So circle back with the patient, with the family, ask them a little more in terms of history if you're starting to get into the weeds and think about these uncommon causes. And that is what I have. Thank you so much for your time. I'll turn it back over to Dr. Winters.
Thanks so much, Mark. That was simply outstanding. I love all of those rare diseases, rare conditions. You did a great job highlighting so many of those along with the critical pearls. So I definitely learned quite a bit from that last discussion. My thanks to you. And